Welcome back, everyone. I have the pleasure of introducing our next speaker, who really needs no introduction. We're going to get started in about 2 minutes, so I'll just invite the last few stragglers to come in from the exhibit hall or wherever you've been hanging out and take your seats. Okay, so Dr. Brian Goldman's CBC radio show, White Coat, Black Art, has been on the air for more than a decade now. He's the best-selling author of several books, including the now classic The Night Shift, The Power of Teamwork, and most recently, The Casino Shift. He's been decoding us for an increasingly curious and frightened public for a long time. He also walks the walk. That's my favorite thing. This man still works regular casino night shifts at his local ED, which is Mount Sinai in Toronto, so he knows what we live every day. He's here today talking about the roads we all walk together in our EDs, the moral injury, the access block, and most importantly, the joy of still finding ways to be of service to our patients. Please help me welcome Dr. Brian Goldman.
Thank you, Zoe. Go get him. Go get him. I am going to go get him. Hi, everybody. How you doing? Has this been an amazing conference? Do you want to give a shout out to Brittany and Tamara and to everybody who has put together this wonderful conference. It's great to be here, and really it's an honor to be giving the closing keynote. You know, Zoe, I do walk the walk, although I have to say I'm kind of embarrassed about the way I walk. At least a half a dozen people have asked me, have I injured myself? And, you know, I'm not the same since I fell and broke a bone in my spine a few years back, early in COVID, while I was running on a wet, leafy street in Vancouver. But I'm here, and I'm still standing. And I'm an antiquated emergency physician who doesn't have the good graces to know when to retire. Anyway, so these are the objectives. Basically, what I want to be able to do is talk about what jazzes me, which are the heroes of emergency medicine, the people who are keeping the light in the lighthouse on, as Dr. Ken Milne is wont to say. And I'm going to focus on the people who are either addressing gaps in the system or who are noticing what's wrong in the system and are taking steps by working within the system or sometimes outside the system through mainstream media and social media and or sometimes other methods, which you're going to find out about, some of which you probably already know about, to advocate constructively for our patients and for one another. My disclosures are very simple. I don't receive funding. I haven't received funding for any portion of this talk other than advocating, and here are some ways to advocate. I'm not trying to sell you any products, although, you know, I did, and I am grateful to CAPE for allowing me to sell some copies of the book, actually, the University of Manitoba bookstore. So shout out to them, because independent booksellers are the foundation of democracy in our system. They're under threat, and I'm glad they still exist. I host, yes, yeah, thank you. Yeah, applause to them, applause to them. I host, as you know, two programs on CBC under a non-employee freelance services contract, and what I'm going to say does not reflect the views of the CBC. So I wrote a book called The Casino Shift, and I don't need to tell you what a casino shift is. I will tell you that emergency physicians and casino workers probably have a bit more in common than we care to admit, and it's a hell of a sexy title for a book. It certainly has captured the imagination of non-medical readers out there, and I'm grateful for that. You all know about hallway medicine, so I don't need to tell you about hallway medicine. What's interesting is I wrote about it in The Night Shift, and when I was doing some digging for The Casino Shift, I wanted to take a deeper dive into hallway medicine. I discovered that one of my mentors, not an emergency medicine mentor, but a writer, a medical writer mentor, Sidney Katz, who was writing feature-length articles about healthcare going back to the 1950s, he actually coined the term hallway medicine, and he was referring to a broom closet on a ward that had been converted into a hospital patient room. Another fun fact, in 2018, Doug Ford promised to end hallway medicine. That sounds like the punchline of a joke, of a sick joke. And early on in White Coat Black Art, Dr. Eddie Lang invited me to the Jewish General Hospital when he was there. And he showed me a corridor with as many as 43 patients in one hallway after another, snaking all the way from the ED to a far-off elevator. So you know, hallway medicine was something that I wrote about in the night shift, and we all know the reasons for hallway medicine. You know, think of the emergency department as that bathtub. And, you know, as Al Drummond would be wont to say, you know, people keep coming in. We can't stop them from coming in. We try by ambulance diversions, and that's like squeezing a balloon and expecting to be able to compress it by squeezing it. You just displace it in another direction. And unfortunately, the drain is stopped up through lack of acute care and long-term care beds. You all know that. Do you realize, do you understand the implications of the fact that we are, as emergency physicians and other healthcare providers who work in the emergency department, we are the surge capacity for the hospital and the entire healthcare system? I don't know if you've ever thought of it that way, but you should, because when I think of it that way, it makes me understand what's wrong with the system, and also makes me understand that maybe we need to get other services within the healthcare system to kind of give back to us, to restore our surge capacity. And that's the thing, that's the advocacy piece that Al Drummond and Blair Bigham talked about a few days ago, and what some of the people I'm going to be shouting out are preoccupied with right now. And you know, in 2011, I talked about the hallway. Well, what happens when the hallway and the rest of the ED is full? You know, no surprise to any of us. You get this. You get waiting rooms that are filled with patients, and it's the norm now to have emergency department. By the way, I love that spell check turned it to EDs. I don't know what EDs are, but anyway, they are EDs. On a regular routine basis, having 50 to 60 patients waiting to be brought into a treatment area, and that's the norm. That's just the normal course of business. And you know, we're trying to cope. We're copers. We're problem solvers. So, you know, give me a waiting room. You know, give me a broom closet to the side or an extra room. Maybe we can hang up a curtain and we can start to schlep patients to that temporary area. And, you know, enlightened hospitals are hiring phlebotomists to do EKGs and blood work to try to desperately to at least do something to start the ball rolling of assessing and taking care of that patient, so that by the time they do get inside the sliding doors, it isn't all dead time, the time that they've spent in the waiting room. And of course, dead time has an ironic meaning now, doesn't it? I'm thinking about Prashant Srikumar, who was 44, went to Grey Nuns Hospital complaining of chest pain. Waited 8 hours, you know, had some things done, had an EKG, had a troponin, and unfortunately he suffered a cardiac arrest shortly after being brought inside the emergency department. And you know, one of the astonishing things about that is that he was one of as many as 3 patients to suffer a cardiac arrest in the emergency department that day in the waiting room. And Dr. Raj Sherman, who is a veteran emergency physician who went the political route, which some of us do, has said famously that Edmonton is the epicenter of probably the worst ER access crisis at this point in time. You know, Alberta's pretty bad, but there are unfortunate stories right across the country. In Atlantic Canada, for instance, and here or there in Ontario, where I practice. This is from an inquest that took place quite recently in Ontario into the death of Heather Winterstein, who presented to the emergency department in 2021 with myalgia. She was seen and discharged and returned the next day with worsening symptoms, collapsed and died of sepsis after waiting 2.5 hours in the waiting room, and the 3-week inquest concluded that the delayed treatment did play a role in her death. So it's happening. You know, if it happens, you know, once every 10 years, it's one thing, but if it starts to happen on a regular basis, then, as you know, we've got a problem, and people, you know, smarter people than I have referred to this as the collapse of the emergency system. I don't think we're there yet, but the fact that we're thinking about it and smart people are beginning to wonder if we're getting close to it, you know, makes me think that we need to focus attention on it. So how do we do that constructively? Well, I can tell you that when White Coat Black Art came on the air, and I'm going to be saluting, you know, some heroes, some of whom you're going to see here, and some I haven't put up on slides, but I'm reminded of someone. I don't know if he's still here today, Dr. Bruce Campana. Dr. Bruce Campana gave a wonderful talk about disruptive physicians and the work that he does to work with them, to rehabilitate them so that they can return to practice, had some do's and don'ts, and, you know, has that grumpy old man demeanor that he had people laughing at a very serious subject, you know, with good reason. He's a wonderful speaker. And I remember that early in White Coat Black Art's history, we debuted in the summer of 2007. You know, the show, nobody ever heard of the show, and getting people like us to appear on the show was not hard. You know, once we explained what the show was all about, we had no problem. And Bruce Cassidy, he may yet be the coach of the Edmonton Oilers or the Toronto Maple Leafs or none of them. No, Bruce Campana, not Bruce Cassidy. Bruce Campana was one of the first people I approached to be on the show, and he introduced me to a couple of triage nurses who were also on the show. They were part of the first 10 episodes of White Coat Black Art. And the show sneaked up on everybody. It went from WTF, what is this, to must listen in a very short period of time. And I would say that I wouldn't be talking to you today if not for people like Bruce Campana. And I remember he came on White Coat Black Art. I went around the country saying, my worst medical mistake was this, what was yours? And people's jaws would drop, but eventually they'd start to talk because they wanted to tell their story. And Bruce told a very unfortunate story with immense courage of a 30-year-old man with autism spectrum disorder who had caregivers, was nonverbal, and the caregivers said, look, can we just give him an enema and get him out of the emergency department? He had some belly pain. And I remember the look on Bruce's face and his demeanor, his slumped shoulders when he said, you know, what are the worst 3 words that you can hear as an emerge physician? And they are, do you remember? Do you remember that guy with autism that you treated for constipation? Well, he died of a ruptured appendix, Bruce said, and that was what was found at the autopsy. And if not for that kind of courage, which is symbolic of the courage of emerge physicians and nurses and other health care providers to speak out, I wouldn't have White Coat Black Art on my resume, and I wouldn't have the pleasure of speaking to you today. So shout out to Bruce and a couple of triage nurses who talked about things from their side of the gurney. So the first wave of White Coat Black Art was people like Bruce Campana and others talking frankly about the challenges, the joys and the challenges of being inside the sliding doors, as it were, being on my side of the gurney, on our side of the gurney. And they spoke readily until hospitals and health authorities began to pay attention to what they were saying on the air and began to point them out. I think we need to have a little talk. And some of them were sanctioned, some of them were suspended, some of them lost their jobs. And gradually, over time, it got harder and harder to get frontline healthcare providers to appear on White Coat Black Art because they were terrified, understandably, of the repercussions. Which brings me to my first two heroes, a couple of very brave triage nurses. Valerie Evanishin and Jamie Hack, they are triage nurses at the Royal Alexandra Hospital in Edmonton, which is one of Canada's busiest emergency departments, certainly by far the busiest in northern Alberta, where they say that they see 80 patients on a fairly routine basis. They told me on the show, they've had as many as 120 souls waiting in the waiting room to be seen. So crowded that they actually have to ask whatever loved one who's come with them to leave. You know, you can go to the parking lot, go to the lobby, go whatever, go wherever, but you just can't be here now, there's too many people. And, there are other issues. They have people who are unhoused, who bring all of their belongings with them, and so space is at an incredible premium. And they talked about the moral injury of those waiting room codes that occur, and they're occurring with increasing frequency. Just do the math. 120 patients would be a healthy 24-hour census in many, many emergency departments. Well, imagine them all there at the same time in the waiting room, cheek to jowl. And how many of them, 5 or 10%? Are there 6, 8, 10 of them that, without fairly prompt attention could code? That's a pretty scary business to be in. And so they talked about the moral injury that they experienced, not just about the codes that occurred when they knew that they could have done better, wanted to do better, but having to deal with patients or family members who are upset about the wait. When will my mother get a stretcher? My dad has been in pain and vomiting all night. And you can imagine just how distressing it is, not just for the families, but for them. What's different here and how you define courage, the definition of courage is doing something when you know that there are adverse consequences that you're afraid of, and in spite of that, you do it. And what's different now about these two triage nurses compared to the triage nurses I interviewed 19 years ago, it's going to be 20 years next year for White Coat Black Heart, is that they knew that they would be censured by the hospital for speaking out, and they didn't care because it was too important to get the message out, and both of them have said they have no regrets for speaking out, and that's why they're the first two heroes that I wanted to be able to shout out. The courage to speak despite knowing that the consequences will be adverse. Paul Parks. I don't know if Paul's still here. Paul's a former president of the Alberta Medical Association and the section president of emergency medicine of the AMA, and he has been documenting poor outcomes from hallway and waiting room medicine all the way back to 2008. He was instrumental in making the public aware. I think it was Raj Sharma who actually leaked cases from 2008, but it was the leaking of those cases and the publicizing of those cases that led to action, galvanized action by the provincial government. They hired physicians, extra physicians, to assess patients and triage them in the waiting room and take care of them, and where possible, send them home. And it worked. It really worked until eventually they backslid, as often happens, and began to withdraw the resources because they cost money. More recently, following the death of Prashant Srikumar, Paul gathered colleagues' cases of bad outcomes and near misses and made them available to the public and on social media. And he, over the last few months, has been on an Alberta speaking tour called Stop the Destruction of Our Healthcare, in conjunction with Friends of Medicare in Alberta. He estimates that he has brought the message to over 5,000 Albertans. And so clearly he's a hero. What does he have to say? Well, he articulates what I've been talking about, healthcare workers not feeling safe, advocating, and that's a massive issue for patient safety and healthcare system improvement. He says he's had colleagues warn him many times, Paul, watch your back, powerful people are unhappy. He's also learned that senior government officials have asked through back channels to try to muzzle his advocacy, and in spite of all that, he continues to bring the message, which is why he is my next hero. A little change of topics. One of the heroes of this conference is Dr. Kirat Grewal, who I'm going to get into in just a moment. You know as well as I do that we've been dealing with cancer. That's part and parcel with being an emergency physician, but for me it was febrile neutropenia. It was dealing with complications, tamponades, SVC syndrome. Really, I've been practicing emergency medicine at Sinai Health System for 42 years now. And when I started, I don't recall making the diagnosis of cancer very often. But now it's routine. And not only are we seeing patients diagnosed with cancer, we're diagnosing stage 3 or 4 cancer. And we know a lot of the reasons for this. We know that the primary care gap is wide and getting wider, and it's increasingly serious. We also know that colorectal cancer is rising at an alarming rate among adults under the age of 50, and there is nothing more injurious than having to tell a 20 or 30-something person with their young spouse and maybe young kids that they have stage 4 colorectal cancer, and it's the start of an awful journey for them. Kirat Grewal was inspired by a close family member with cancer, and that made her want to change things. And she is an advocate of a different kind. She's a scientist, a pure scientist working at SREMI, a major influence here at CAPE and in our environment at Sinai. In that capacity as a clinician scientist, she discovered that emergency use prior to a diagnosis of cancer portends a higher mortality. And it kind of makes sense. These are people who are being diagnosed at a later stage. Of course, it's correlation, and as a pure scientist, she wants to know why that's the case. And that's one of the next focuses of her research. At ISIS, where she's a scientist, she published a paper showing that more than a third of patients diagnosed with cancer in the emergency department used the ED in the 90 days prior to diagnosis. Now, again, that's a correlation. You can begin to speculate that maybe these were people who went to the emergency department with symptoms and did not have access to primary care. Maybe without primary care access, they didn't get cancer screening. Those are all speculative, but she's generating the data that's raising more questions. She's also interviewing us. That's through qualitative research, and she has found, not surprisingly, because this is confirmation of something that we already know, that emergency physicians find the current processes for managing patients who don't have primary care with a new cancer diagnosis incredibly challenging and very distressing for us. I don't want to send a patient home without knowing if they're going to get a biopsy. I can't send them to a clinic without a biopsy, because where do you send them? Unknown primary clinic? That doesn't exist. Well, it does exist in some places. Some people are doing it. Kirat is not only trying to generate the research that asks the questions and gets the answers, but she's also working with the forces of healthcare in Ontario to improve and facilitate the care of patients with cancer in the emergency department, and that is why she is one of my heroes. Here's a different story, the story of miraculous Maddie. Maddie was with her family at a Red Cross garden party in England. She was 2, and she slipped out of her stroller and wandered off. She's found face down in a pond, cyanosed and in cardiac arrest. Now, mind you, and fortunately, this was a Red Cross garden party. And a bystander from the Red Cross garden party pulls her out of the pond and does CPR, and the little girl is saved. And today, miraculous Maddie is married with 2 kids of her own. And her older brother at the time, 5 years old, never forgot that and wanted to give back. So let's see her older brother. That's him. That's Dr. Nick Sparrow. Dr. Nick Sparrow graduated from medicine in the UK and did his residency in South Africa and did some early work back in the UK. And he worked alongside physicians who repatriate patients from austere locations, who resuscitate them from austere locations, who aren't paramedics, but are physicians, bringing their physician scope of practice and their skills. And he thought, hey, that's a great idea. And he came to Canada, this sparsely populated land of ours, and discovered that nobody was doing it. Nobody across the entire country. So he said, I'm going to invent it. And what you see there is he's standing beside his truck. It was donated by Toronto EMS, completely refurbished, and it has not only all of the paramedic type equipment, but the stuff that we use. You know, he can give IV ketamine, he can paralyze patients and do video laryngoscopy intubations, he can put in central lines, he can put in chest tubes. I have no doubt that one day he will be able to do ECMO, because that's Nick Sparrow. He probably won't be able to do it by himself. And he founded something called KIRPA, which is the Kootenays Emergency Response Physicians Association. And the mission of KIRPA is to not waste that golden hour that sometimes stretches into 2, you know, when you've got patients who need to be rescued from mountaintops and snow wells, but to actually bring the emergency department to them instead of waiting for the patient to be brought to the emergency department. Patients like Mirek Hladek, who gave consent for this story to be told. He owns an brain fart. He owns an aluminum fabrication plant, makes all kinds of things out of aluminum, and he was in his basement. He's pointed to his basement down there when he was trying to move a concrete panel that was part of a stack of concrete panels, and unfortunately it started a chain reaction and they fell onto his left ankle. And he suffered a compound fractures of his distal left tibia and fibula. And as sometimes happens, on Nick, it took him a lot of effort to be part of the EMS system, where he would be contacted at the same time as the paramedics if it was felt that his skills might be necessary. And he turned out to be the first on scene, which happens not infrequently. And he found that Mirek's foot was pale and pulseless. And he started to do some calculations in his mind. He figured that with a 15-minute drive, he could drive Hladek to the nearest hospital, that hospital was probably not equipped to do the reduction and restore the circulation, and it would be another 70 to 90 minutes to the next closest to the regional trauma center. And Nick decided to act on the scene by himself to save the foot. He set up an IV, put in ketamine and midazolam, gave antibiotics, irrigated the wound, attempted to reduce the fracture, and then discovered, I can't put this back in, and he discovered the reason. The skin was tethered. The skin over the ankle was tethered, and he needed to put in some local anesthetic and incise it. And he did, and he was able to put the ankle back into a reasonable position, restored the pulses. So at this point, Hladek was good for transport. And he was doing well 4 years later when I spoke to him, and you can see a close-up of his ankle, and it looks pretty good. That's a good save. And Nick Sparrow is not done with this effort. I met one of his colleagues here at Cape this year. There are now 3 crews, 3 vehicles, 3 physicians. KIRPA has been awarded a highly prestigious award by the Commission on Accreditation of Medical Transport Systems, and it's an extraordinary honor. Nick is a stickler for quality assurance, making sure that he does it right and that there are no adverse repercussions or that they are minimized. He has responded to 1,700 immediate life threats that are 911 type calls, and will continue to do that good work for as long as he is able. What the future is for Nick, he has said if no other physicians want to step up and do it, it won't have been in vain, because he'll have helped a lot of people. But it turns out other physicians are stepping up. His story has inspired Dr. Michael Christian, a colleague that I remember from Sinai working in the ICU. Mike Christian is an ICU physician who is spearheading a pilot project called MedResponse BC to evaluate the impact of a province-wide provincial model of pre-hospital and retrieval medicine care in British Columbia. So that's where inspiration can take you, and that's why Nick Sparrow is another one of my heroes. Caitlin Stockton, who surprised me by showing up for this conference. I was told Caitlin wasn't going to be here, so I just thought I could blather on, and I guess her ears started to burn. Caitlin is an amazing young woman in mid-career, and you probably know a lot about her story, but you may not know some of the details which we featured on White Coat Black Art. From 2017 to 2025, she worked as an ED physician at 2 hospitals in Fraser Health, which is BC's largest health authority. And she and her colleagues saw and witnessed and documented dangerous overcrowding and other factors that led to safety issues for her patients and her frontline providers. She and her colleagues raised concerns with authorities on numerous occasions, and they were not dealt with. And so you probably know that story. You may, unless you spent time in British Columbia at the time, you may not know the details of what happened on November 18th, 2024, because they're very instrumental in what happened next. I'm going to talk about them. Stockton tells me she arrived at 6 a.m. for her regular shift at Eagle Ridge Hospital with 2 available stretchers, and that's the story, the same story that they have at Royal Alexandra Hospital with the 2 triage nurses, Valerie Evanishin and Jamie Hack, that I told you about previously. She tells me that they usually see 150 patients per day in that hospital, and that 10%, about 15, need an acute monitored bed. So they need their stretchers. And soon after she arrived, 2 patients crashed, and at that point they had no stretchers available, and they continued to have that, that tap, that flow of arriving patients, arriving by ambulance and by foot and by car. And other physicians began to arrive later and later in the day, in the morning, and they were conferring with one another, and they pleaded with the hospital leadership to do something, to move admitted patients to the wards, to cancel elective surgeries, to redirect ambulances. They asked for a code orange. All of these were refused. So not just Stockton, but all of her colleagues there, and with the permission of the emergency department director, they posted a number of signs, and that's a sign there. You can see it, you can read it for yourself. And she was not the only one to post a sign. Others did it. They posted them in several places. But Caitlin's involvement will become clear in a moment. A photo of the sign was posted on social media and reported by the local media. Not surprisingly, it was a bit of a sensation. And the authority, the health authority, issued a fairly quick press release calling the sign false. And after that, senior executives presented Stockton with closed caption video. Imagine this, we think of having surveillance video for security purposes, to make sure, to see if somebody had a weapon, what happened when somebody was violent. Sometimes when a patient leaves against medical advice, we want to see what direction they went in. Imagine using that closed video to monitor us. And that's what happened on that occasion. That's how it was used. She was asked to apologize and say the sign was false. The sign was not false. She didn't apologize. She was threatened with loss of hospital privileges and a complaint to the College of Physicians and Surgeons. Now, most of us would not have the courage to do what Caitlin did eventually, many months later, in June of last year, 2025. Most of us would back off. We would probably apologize. We would be suffering moral injury from what happened. She couldn't do that because it wasn't right, and because it left an ongoing threat to patient safety and to the safety of she and her coworkers. And so she did something that I have never heard. Now, there are probably a half a dozen cases in civil case law in which physicians have sued the hospital. And in some cases, they've won big awards, usually for bullying allegations. Well, Caitlin Stockton did that. And I have never heard of a hospital a health authority being sued by a lone physician. And that in and of itself is absolutely remarkable. Now, what happened after that, we don't know. The case was resolved to everybody's satisfaction, and the terms have not been released to my knowledge, are not going to be released. Caitlin is not finished. She continues to be a passionate advocate for better emergency care, better treatment of frontline providers. I would watch very carefully the next thing that she's going to do. And what she hopes to be able to do is to create a system that has never existed before, a system of accountability that would be publicly accessible so that the public would be able to know what hospitals in various regions are doing to manage the workload, to manage the wait times for patients, and to make sure that hospitals in those health authorities are running as optimally as they could to the betterment of the public. And I would watch very carefully what she does next. The other thing that I want to note about Caitlin is that she was inspired to set an example that her kids could follow. That is it's sometimes called a Macau fishhook. It was featured in the film Moana, the animated film. It's a Polynesian symbol of strength and prosperity. And her son showed it to me because he gave it to Caitlin to help her, to help burnish her courage for the battle that lay ahead at the time, which I think is remarkable. And that's why Caitlin is one of my heroes. You've already heard a little bit about this horrible tragedy. September 2nd, 1998, Swiss Air Flight 111, taking off from JFK. It crashed at 10:31 in the ocean just off Peggy's Cove. 215 passengers and 14 crew perished. It was the second deadliest air disaster in Canadian history. And at 3:45 a.m., several hours later, a senior medical student from Dalhousie is awakened by a knock from an RCMP officer. And the guy on the other side of the door says, "Trevor, we have a civilian airliner down and I need you to report to CFB Shearwater." Why him? He's the reserve soldier with pathology experience. And it turns out that it was the right call, and Trevor talked about this yesterday in a completely different way. I'd like to reframe it just a bit. He was 28 years old, and he wasn't even a physician. He was in his final year of medical school, and his pathology experience came from volunteering in the pathology department because he was curious. He was curious about how autopsies were done. He was curious about plastic surgery. He was curious about those things. And eventually, his curiosity led to him being hired as a pathology assistant. And that experience became very, very important in what lay ahead. It also allowed him to pay his way through medical school. And he arrived at CFB Shearwater into Hangar B, and it was chaos. Nobody seemed to know what to do. He talked about the ICS, setting up an incident command, and all of that is true. But he looked around and saw chaos in front of him. He saw physicians packing up to leave because what had been a rescue operation was very quickly turning into a recovery operation. And he saw out of the corner of his eye some dudes having difficulty getting a portable X-ray machine off the back of a truck. Well, he was a curious lad who worked in a hospital and I guess was curious enough to know how the portable X-ray machines worked, and all he had to do was flick it on and put it in reverse, and he was able to get it off the truck, and people began to come to him asking questions because he was the dude who knew how to get the X-ray machine off the back of the truck. He tells me that he got up on a bunch of boxes and surveyed the situation and very quickly worked out a plan to create order out of chaos. He knew what a pathology autopsy room looked like, what it needed, and he drew out one and eventually 12 of them. All of that, he did in about 48 hours. Dr. John Butt, who was the medical officer of health tasked with being in charge of the recovery operation, got a tour from Trevor. He was answering all his questions. Dr. Butt thought that Jane could be his assistant until Dr. Butt's assistant said, "Oh no, you don't understand, Dr. Butt. Captain Jane has actually set this all up." And John Butts thought about it for a second and said, okay, you can be in charge of this place. He was 28 years old, and he wasn't yet a physician. And under his leadership, his brilliant teamwork leadership, every soul, every passenger crew member on that flight, Swiss Air 111, their remains were identified. He gets teamwork in his bones and is so sensitive to the needs of others that he tells me that when he received word that the recovery operation, the recovery divers were about to bring in some remains of an infant or a small child, that he made sure that people who had young children weren't working that day. He gave them the day off. That's how sensitive Trevor Jane was back at that time. And of course, he continues that work today. He is a brilliant trauma and ED physician. You heard his talk yesterday. You don't need to hear him. He has won all manner of accolades and awards. He gets teamwork, and he is now a passionate advocate and defender of emergency care with CAPE. And that's why he's one of my heroes. Oh, one more story. On a dark and snowy winter night, Jane had finished a shift in the emergency department and was about to go home, and they heard on the radio that paramedics were about to bring in a 16-year-old who was found on a snowbank dressed in a T-shirt and jeans. It was Jane's birthday. No problem. Got back into his scrubs, got the two most experienced nurses he could get a hold of. He had no ECMO. When the teen arrived, his core temperature was 26 degrees Celsius, and when you touched his skin, it was rather like. For the next 7 hours, he and the nurses used every method aside from ECMO to rewarm him. They shocked him 14 times over a 3-hour period to no avail. Then, at about 29 degrees Celsius, his heart rhythm became irregular. To Trevor, that was a sign. Maybe something was happening. By 31 degrees Celsius, they got a pulse, and the teen awakened in the ICU the next day. Today, he is married with kids and works in the fishing industry. And the only thing he lost on that day were a few fingers from frostbite. After that save, Jane went home. He says that he just went upstairs and looked at his daughter who was sleeping. He checked in on his wife and then sat in the sunroom and watched the snow coming down. Some stories make you angry, but some stories make you cry. And every time I think of him sitting there watching the snow, I'm about to lose it. That's why Trevor is one of my heroes. Two more heroes. Dr. Catherine Varner, a brilliant emergency colleague who you all know and love, as we do at Sinai, who's the deputy editor of CMAJ. I wrote 150 articles for CMAJ in the News and Features Department in the 1980s, so she's kind of a kindred spirit of mine. She's a great writer. She has a master's degree in clinical epidemiology. She, like Kirat Graywall, saw an enormous gap in the care of women who experienced miscarriages and other pregnancy-related emergencies, and has created a wraparound system to take care of them. That's why she's one of my heroes. Dr. Lisa Salomon, who is another brilliant emergency department colleague who worked initially at Scarborough before coming to Mount Sinai. She ran the COVID-19 vaccination program there in one of Canada's largest districts. She served as the Ontario Medical Association's District 11 chair, which encompasses the Greater Toronto Area. She speaks out for faculty experiencing harassment, and she's the winner, one of the winners of the 2025 University of Toronto Award. Hers was for excellence in social responsibility, and this is what it was said about her. There's no better example of ethically driven social responsibility. She shouts out for people who are downtrodden and for people who are likely to be criticized. And she does it in spite of being criticized, and that's why she is one of my heroes. And it's really uncanny when you look at this, because I picked out all these people, and then a little while back, what was it, a month ago, 2 months ago, this little paper came out, this little position paper. Harassment and bullying of emergency physicians by organizational and system-level administrators, by CAPE. Take a look at the names and see if you recognize any of those names from the presentation that I just did. Yeah. So these are people who not only are heroes in their own environments, but they're heroes for the greater good across Canada for organizational emergency medicine. I want to end by talking about where it all began. Perth, Ontario. A little hospital that used to be called the Great War Memorial Hospital. They still call it the GWM. But these days, through amalgamation and those gangly titles, it's now known as the PITH. I love it. The Perth and Smiths Falls District Hospital Great War Memorial Site. Try to say that 5 times in a row. It is the first community hospital in Canada and the 5th in Canada to do robot-assisted knee replacements. They do high-volume joint replacements and excellent outcomes. And they have a small but mighty emergency department with 10 stretchers and 25,000 visits a year that I had the pleasure to attend a couple of years ago. And of course, you know the guy who started there in the 1980s, became the medical director, and came on a mission to recruit and train physicians to practice emergency medicine there as a specialty. He said, if you're going to work in the emergency department, then you're going to fully commit to maintaining skills. And he trained them. He brought in ACLS, ATLS, airway courses for physicians and nurses and other providers. And he had the nerve to ask for feedback from hospitals in Ottawa and Kingston, where they were transferring patients, to ask, how did we do? What can we do better? That's a little bit closer to what Al looks like today. He was the president of CAPE in 1992. He has, for 23 years, he was CAPE's principal spokesperson. He was active in highlighting the public health aspects of firearm injuries throughout. He continues to do that. And he advocates to end hallway and waiting room medicine, not through empty promises and wishful thinking, but through evidence-based means like just do what you're supposed to do, what I've told you about, he says with a heavy sigh, for the last 40 years. More beds, more long-term care beds, put your money where your mouth is and take care of it. And of course, among his legacies is CAPE's Dr. Alan Drummond Advocacy Award, honoring one individual who has gone above and beyond normal measures during the previous 12 months. And of course, Caitlin Stockton won that award this year. And, you try to tell him he's doing a great job, and the first thing he says is teamwork. It's not me, it's the team. It's the team that I produced. It's the team that I didn't produce. It's that he won't say that. He would never say that. The team that kind of grew up all around me as if by some coincidence. And I've spoken to those people who work alongside him today, and they love the place. They love him. They think it's a great place to practice emergency medicine. That's a 10-stretcher emergency department with 25,000 visits a year, and it's a destination. And I think that's just a remarkable achievement. If he had no other achievement, that would be remarkable by itself. So to sum up, here are some of the things that we've learned. Run up your complaints up the chain of command like Caitlin Stockton did. If you get no response, use the media and social media to tell Canadians. I think that Paul Parks could tell you about that. Nothing gets the attention of Canadians like leaked cases. Raj Sharma could tell you about that. Probably Paul Parks could as well. Find and address gaps in the system like Catherine Varner and Kirit Graywall. Use your unique skill set. Be the Canadian Forces Reserve soldier who knows how to get the X-ray machine off the back of the truck. Courage. Know the repercussions of speaking your truth, like Caitlin Stockton, like Lisa Talman did. If the powers that be don't listen, consider suing them. Okay, maybe you won't. I would be surprised. I'll wait for the next person to do that. Oh, and I have one more tip for you. If all else fails, ask what Al Drummond would do. Thank you. It's been a pleasure and an honor to be invited to the conference. And I hope you go forth and take some passion and inspiration from this conference and know that your colleagues punch way above their weight. That's what we do. That's what we who work in emergency medicine do.
Thank you. Thanks for having me. Thanks again. This was an absolute pleasure to hear you speak today, Brian. I must say your voice sounds exactly like it does on White Coat Black Art. So it's like meeting a celebrity for us. Are there questions from the audience? We have about 10 minutes here. If people can make their way up to the microphones and ask what you want to ask. Okay, we'll take one from over there.
Hello, thanks, Dr. Goldman. Initially, I was going to ask if you think there's one character trait that all your heroes share, but I think it would be courage. Is that right? Would that be fair to say?
Bluntness.
Okay.
It's the work that we do. We work in 6-minute aliquots and 7-minute aliquots. We're used to being at codes. I think we bring that code behavior to our social discourse, especially when we are exasperated by the working conditions that have been foisted upon us.
I do have a quick follow-up. Courage is important, I think you've emphasized. As early career physicians and senior residents, how would you encourage us to develop courage in our day-to-day?
The first thing that you do is learn from the mentors that I've shown. And I will say, learn to temper your courage. These are people who have learned to speak out because they have nothing to lose at this point. And it may be that they've reached a point in their careers where they feel strong enough, they feel that they're too important to be pushed out, they can go elsewhere. They've stared into the abyss, they've seen the worst that can happen, and they've reached the point where the price of doing something doesn't seem so great. I think if you ask them, if you're a resident or just starting out in practice, should they do what you do to those mentors, they would probably say, wait a few years. Get some experience under your belt. You have far more to lose at this point, because not only might you be censured, but you might find that the whisper campaign makes it difficult. If you are forced to leave that institution, that you might find it difficult to get a job elsewhere. So I would say be careful in the first few years.
And on your left here, go ahead.
Hey, Brian. One of the sad parts of your story is that a lot of the battles that you have stated have to do with people fighting medical and political leadership. And I'm just wondering if you think that's innate in our system, or what does it say about the failings of our institutions that sometimes the people that lead us are more apt to protect the system rather than the patients and those that work in them?
I can think of several answers, several factors. One of them is that we're in it for the long haul. We're in it for our careers. Politicians are often in it for the next election cycle. They're just not working according to our our time frame. The second factor is that they don't see things from our point of view, and certainly one of the most important things that we can do to try to bridge the gap is to invite them to come and see what we do in the emergency department, to sit in our shoes, or to stand in our shoes and to walk around as we do. And sometimes politicians are willing to do that. But there's no question in my mind that they only care when there is the potential for blowback against the government. Short of that, I don't think they care. Maybe they go into healthcare leadership, healthcare administration, healthcare politics, wanting to do good, but very quickly they may come to the conclusion that there are too many competing priorities with the government, and they just aren't addressing the issues that Al Drummond has talked about repeatedly.
Thank you. I'll ask one of my own, if I may. You're talking today about finding light in the dark, essentially, and there's a lot of dark. Doing better or more when often we're all exhausted and it seems a bit impossible. I run into people every once in a while who say, why do we have to keep doing this? It's another Band-Aid, another workaround, another plugging a hole in the proverbial dike. What do you say to those people who say that this ongoing innovation and our efforts to find more ways to do more just facilitate the ongoing dysfunction of the larger healthcare system in general, when they're happy to let us just fix it?
Well, we have to find joy, ecstasy, satisfaction in the work that we do. And I would, Zoe, I would put it to you that if the good people that I've talked about and many, many others weren't fighting that fight, didn't have that passion, remember I said it's the passion that sustains us, not the passion that defeats us, then that would be burnout, and they would leave. And the system would be the poorer for it. So, my passion is telling stories about us. I want people to understand what it's really like inside the sliding doors, and I have found that when I indulge my passion, I feel better about my work. And I know that Kirat and Catherine feel better about their work because I work alongside them because of what they do, because they're trying to make the system better.
So advocacy and innovation is a way for us to stave off our own burnout,
Right.
And find the passion. Why are you still here? You've been doing this for a long time. You work shifts for a long time. What is it about the shifts still and the daily grind that brings you joy and that passion?
The joy comes in after, my colleagues kind of look at me with a sideways glance for spending 2 hours after my shift. And part of it is after the grind, this rapid grind that I start fresh and I get progressively, more delayed as I have to reassess my patients, that I lose that cognitive bandwidth, that opportunity to think about my patients. And it's after I've stopped seeing fresh patients, new patients, somebody else has taken over, that I can finally start to think. And it's in that slow thinking that good things happen. And, as long as I, continue to be able to put the pieces together and make a diagnosis so that my referrals to IM and surgery aren't laughable, then that seem credible, then I continue to make a difference. The other, I like that part of me. And one of the things when I was asked to give this talk, I thought that I might want to give a completely different talk, which I could come back and do some other time, called Not Shy and Not Retiring. And I would love to see us think about how we might be able to use our older colleagues as they inch towards retirement and maybe even beyond. And I have some ideas. It's not, if you're 40, I don't expect you to be thinking about it. But if you're 60, then we should get together and have a chat, because I think there's things that we can do to still make a difference.
We need every single one of us to make that difference in whatever way we can at whatever stage we are at, which is nice to be reminded of sometimes when we're feeling burnt out or exhausted or maybe at the end of our rope. Thank you. This was an absolute pleasure. If anyone has one final question or they want to approach the podium afterwards, Dr. Goldman has 2 or 3 minutes. Thank you. It's an honor.